Thank you very much, Janice. I love coming to the EVACNE meeting. She makes fun of me for calling it that, but I'll never stop calling it. So I'm a general surgeon by training. I went into Vascular Access. I became the president of the Association of Vascular Access. And in fact, in 2018, they gave me the Suzanne Herbst Award. Most of you weren't there. So this is Suzanne. This is Suzanne handing me the Herbst Award.
I'm giving you this container for your ashes.
I asked her if I had to use it today. You know what I mean? But anyway, this is today's topic. A topic that's not spoken about nearly enough. You know, it's about the relationship between the way the person puts in a line and the way it's cared for, if you ask me, right? These are my disclosures. I do speaking for the following companies, and for that reason, I am biased. So I'll declare that. So what's the goal in all this? The way I see it, and the previous speakers have been talking about this, is we're trying to standardize practice at the highest level because we work on human beings. But like, what's the big deal? You hear about this all the time. You know, it's standardizing practice. It's like Toyota manufacturing, the airline industry. We're standardizing practice. What do you get out of it? It can eliminate unnecessary variation. And what do you think unnecessary variation does to your outcomes? Nothing good, right? So you want zero CLABSIs, huh? Isn't that a noble goal? But there's a couple of facts that get in the way. Number one, we're inserting plastic tubes, inanimate objects, through the bacteria-laden skin, as Nisha Gupta showed us earlier. We're doing it directly into the bloodstream. We're doing this in immunocompromised patients that are actively infected. If you think that's a recipe for zero infections, I'm here to tell you maybe not. But, and when I'm in front of infection control practitioners, I usually tell them, in 50 minutes, I'm going to ask you a question. And I'll tell you what the question is. The question is, what do you do to prevent infections? And for the next 50 minutes, I'm going to tell you what we do to prevent infections. Now, we can't change their immunocompromised state or the fact that they're actively infected. We can give them optimal vascular access, and they deserve nothing less than that, right? So let me describe what I see as the problem in this business, right? The state of acute vascular access in the United States of America is deplorable. I'm sorry. You cannot do this and think that you're doing the right thing, you know, for the patient. It has to change, right? So to me, like, my superpower is I can tell what a CLABSI looks like before the blood culture comes back. It looks like this. You know what I mean? So if you found this, if you found something like this, who would you bring it to? There's nobody in your institution that you can knock on their door and go, oh, do you see the patient in bed 7 in the ICU? It's a real mess. Like, you know, nobody really cares, you know? But somebody has to be in charge of vascular access. And I travel around, I get to visit a lot of hospitals, and I find a certain number of things, and 5 things. Number one is nobody's in charge of vascular access. It's hard to get very far if you're trying to improve things and nobody's in charge, right? Sustainability. You know, like, yeah, we want to figure out good things to do, but we want to make it sustainable for the next generation, right? But there's something wrong. There's something wrong. In other words, this junky practice is tolerated, right? So like, what can you infer? If you come across something like this, what can you infer about the inserter? He needs remediation. You know what I mean? You can't have him, you know, doing this. What about the person that trained him? What could you say about the person that trained him to do that? He shouldn't be training people, you know what I mean? Then suppose the ICU director comes in the morning and finds this. What should he do about it? Should he leave it or should he fix it? Do you think there's anything in the literature about that? And like, you know, for the emergency department, there's this philosophy. Oh, don't worry, they'll fix it upstairs. Hey, ED, they don't get fixed. They don't get, you think there's somebody looking to fix your problem upstairs? That's not how this works, right? So I'm rounding in an intensive care unit 2 summers ago. I was in the hospital for 10 weeks trying to improve their vascular access procedures, and we found this, right? We found a central line dressing attached to somebody's earlobe. Now, let me go on the record. If I need my central line attached to my earlobe, I want that person to do it. Look at that. It's lying flat. There's no pleat. That's the way a central line on the earlobe dressing is supposed to look. You know what I mean? Don't get me wrong. But, you know, I'm rounding with decision makers, and that's the key. I had the chief of the ICU, the chief medical officer with me, and basically I pitched a fit. But without raising my voice, without being a fool, I'm there like, no, you can't do this. You can't put in lines like this. We're attached to the earlobe. It's wrong, you know, that kind of thing. 2 days later, it was still there. And so I was in the coffee shop with my son, and the chief of the ICU was walking by, and I called him over for a little conversation. It went something like this.
Hey, Dr. Blake.
Yes.
You know that patient we saw 2 days ago with the central line dressing attached to the patient's earlobe?
Yes.
That line is still in place. And it kind of indicates to me that the leadership of the ICU is willing to tolerate a poor quality of care.
And by the leadership of the ICU, do you mean me?
Now, in point of fact, that didn't work out for me. Like, I have to learn how to do it besides the frontal, like in your face, punch to the nose. Like, I have to learn a different way, you know? But it tells me that, you know, the leadership was willing to tolerate a poor quality of care. So on one hand, that's really bad. But on the other hand, there's a place, we have a point of call where we can deal with this. But like, you can't fix the problem if nobody accepts responsibility. It's not going to magically get fixed. Somebody's got to be in charge of this stuff, right? So, so here's a patient. Here's a patient here, and basically every nurse in the solar system would like to care for this dressing here, right? And so I want to ask, what antimicrobial products or techniques do you see there? And it's like, you're vascular access experts. I'm going to ask questions. A lot of them will be extra credit. I won't deduct anything. For this one, I may have to deduct if you get it wrong. What do you see there? It's like a reflex, like BioPatch, CHG sponge dressing. What else do you see there? It's a sutureless securement. It's sutureless securement. The dressing's lying flat. It's an antimicrobial catheter, which Nisha. So, what is the difference between the two? What's the difference? It's not inserted properly, right? And you can't get past that. You know what I mean? And if we're going to use the jugular veins, we want it to look like this, right? So basically, Nisha and Matt Gibson and myself, we're sponsored by chlorhexidine-containing products today. You know what I'm saying? And like there's a question I deal with Nisha all the time, right? It's like, all your products are going to work better if the line is inserted properly. Sure, there's an antimicrobial catheter there. It's not inserted properly. All right, so what are the hurdles? What's between this kind of practice and this kind of practice over here? Like what's in between? Like, tell me, what's preventing us from going from this to this? So, we'll say it? Consideration, yes. Intention, knowledge gap. Like if you don't know there's a better way to do it, then, you know what I mean, then you'll keep doing it that way, right? And like, there's a book called Why Hospitals Should Fly. I recommend it. It's a novel. And in there, one of the lines is, the most dangerous words in the English language are because that's the way we've always done it. And it's a big hurdle, right? Training. If somebody was trained to do that, how are you going to get them to do this? You know what I mean? Fear. What are they scared? Fear of what?
Dropping a lung.
Dropping a lung. Fear of pneumothorax. Excellent. Yes. Extra credit question right there. The attending staff. Like, so if you're a resident, you see like there's a better way, but the attendings don't do that. You're a little trouble. And then the old ego. You ever see a physician in the ICU with an ego issue? Yeah, it happens. You know what I mean? All right. So that's the problem. Sloppy practice leading to bloodstream infections. And we're like, did I make it up? I mean, you've seen this, right? I mean, yeah, sure you have. So what's the solution to this? How do you prevent infection? My mother, the late nursing supervisor, passed away during COVID, said there are basically two ways to do things. The right way and all the others. And we got to try to get to the right way, right? So to prevent an infection, you have to do everything right. That nurse in ICU invades that line 25 times a day. You got it up in the hair, you know what I mean, or someplace crummy, and she's invading it 25 times a day. You're going to have a bad outcome, you know what I mean? Basically, we want to put the lines in properly, wrap them with chlorhexidine, and dress them properly, right? So toward this end, so I'm trying to explain it to you guys and also to the critical care doctors. I came up with my framework, the life cycle of a central venous catheter, with the goal of standardizing practice at each phase of the life cycle at the highest level. And the life cycle goes like this. The first phase is the assessment phase, followed by pre-insertion. What you know is the insertion bundle. The actual insertion of the device, dressing, care, and maintenance, and the removal. Anything bad or anything good happens in one or more of these phases because that's all there is and that's all there'll ever be. Now, these slides are going to be available on your website. You don't have to be an OCD note taker. If you want to take notes, be my guest. Another way to look at this is the chain of CLABSI prevention, and the chain is only as strong as its individual links. Okay, going through the different phases. The first phase, the assessment phase, it's been addressed today. It's vital. You've got to get the assessment phase right. Like, the model for this framework is phase 2, the insertion bundle. In the insertion bundle, evidence-based at the highest level. What they're doing in Sydney, Australia is what you're doing in Syracuse is what I'm doing in Baltimore. We're all doing the same evidence-based practice. We have to translate that to the other phases of the life cycle, right? The assessment phase. Essentially, there are good reasons to put in a central device, and there are bad reasons. Good reasons include hemodynamic monitoring, TPN. You can't do hemodialysis without a central venous catheter. Peripherally incompatible meds. This photo was sent to me by the immortal Joe Bunch from Chicago. And basically, this patient received a high dose of bicarb and levofed through a peripheral line in the antecubital file. He didn't get CLABSI. He did not get CLABSI. He got an amputation. And let me explain. You see the blistering? It tells me all the tissue between the vein and the skin is dead. And then the skin blisters there, right? And then Matt Gibson showed this immortal picture earlier. Multiple access and critical illness. Hey, central line. You know what I mean? But there are bad reasons to put in one of these devices. The worst reason essentially is general access. Hey, Dr. Dunn, I couldn't get a peripheral IV. Could you come put in a central line? I did that for decades until we developed a strong nursing vascular access team. And then Jonah would take care of it with her ultrasound, right? Another bad reason is just in case. Those ICU nurses with those like 3 or 4 peripherals that aren't working. My favorite thing is the peripheral IV, that's nursing, but we're going to leave it just in case. Just in case we don't have an infection. You know what I mean? And then if the patient is a difficult IV vascular access patient, basically we want to go to an ultrasound-guided peripheral or midline before we get into the central circumstance. This simple scenario will cover 97% of your patients. But basically, it's have a good reason to put in one of these devices, right? Moving on from the vital assessment phase, we come to the pre-insertion. What you know is the insertion bundle, right? Originally described by the CDC and the Institute for Healthcare Improvement, validated by the Keystone Report, Dr. Peter Pronovost, Johns Hopkins Anesthesia, the lead author, December 28th, 2006 in the New England Journal of Medicine. How's that for pedanticism? Basically, this phase lasts from the time you do your hand hygiene until you drape the patient, right? And it consists of 5 things, and we all know them, standardized internationally around the world, right? So the 5 elements of this are hand hygiene, chlorhexidine skin prep, maximum barrier precautions, daily review of necessity, and avoid the femoral site, right? So basically, I ask, how long does it take to do hand hygiene? It takes me 30 seconds. You know what I mean? Work it in, right? How long does it take with chlorhexidine skin prep? How does that work?
30 seconds.
It's 30 seconds of a vigorous back and forth friction prep. It's not circles, it's not betadine. You're working it in, like Nisha said, to the deeper layers where there's some bacteria. You're working it in as far as you can, right? How long does it take an expert to get maximum barrier precautions on a patient? About 30 seconds, 60 seconds, right? Daily review of necessities, a little strange. Like if I evaluated the patient yesterday and I show up, I know immediately whether he needs the line or not. But if I don't know the patient, I look through the chart, and what do I look at? How sick is the patient, what meds are they on, and what's their access, and I make a decision. So I say on average, it's 30 seconds, more to just keep it in line with my little scheme here, right? And like, how long do you think it takes me to avoid the femoral vein?
1 second.
Yeah, 0 seconds, I get it. I'm just like, now, I've been asked, the HICPAC committee of the CDC asked me to rewrite the insertion bundle, right? So what I did was, I took out daily review necessity because it's not an insertion practice. It has nothing to do with the way we insert the lines. It's clearly a care and maintenance practice, so it doesn't belong on that list. But when they came up with that list in 2006, they didn't know where insertion stopped and care and maintenance started. So I'll help them, right? The other change I made was, instead of avoid the femoral, it's avoid the groin. Now my point on this thing has been credited with a 5-fold decrease in the CLABSI rate. It takes 90 seconds to do it. If you want to tell me it takes 4 minutes, I'm not going to argue with you, right? There's a lot more to vascular access than these 90 seconds. This is ridiculous. It was probably silly in 2006. It's ridiculous today if you think that you do these 90 seconds optimally, you're going to get a 5-fold decrease. I'm here to tell you no. It's like you're crazy if you believe that, right? So basically, in today's lecture, I'm going to cover 5 procedures. I'm going to sprinkle them around a little bit, right? So the first one is going to be the mid-thigh femoral, right? So basically, this is what it looks like. And the question to you, vascular access experts, do you think that the mid-thigh femoral will be a benefit to the patients in your institution?
Yes.
Then you have to learn how to do it. It can't be like, oh yeah, that looks great. We're not going to do it. We have to learn how to do it, right? This is Matt Ostroff from New Jersey, good friend of all of ours, and this is his paper. And this is basically how you do the mid-thigh femoral. It's about 14 centimeters below the groin crease. Much cleaner. No motion is bad for dressings. We try not to cut the skin because the skin is a natural barrier to infection.
I'm just going to come out.
I think it's a great procedure. All right. So, moving on to phase 3, the actual insertion of the device, right? And my motto for this is, insert the catheters properly. It's ridiculous in 2024 you have to say that, but you do. This phase 3, the actual insertion of the device, lasts from the time we drape the patient until we put on the dressing. Once I slap on that dressing, intensive care unit, by definition, the patient is now in care and maintenance, right? And basically, in this phase, and I'm an inserter, this is the fun part for me, we're going to try to figure out what are the best practices and then do the best practices. We're not going to say, hey, that's a best practice, and we're not going to do it because that's irrational. Right? I call this the Trickle-Dunn hypothesis, named after the great Nancy Trick, Royal Oak, friend of Laurie Crozier, from Royal Oak, Michigan. It goes like this. The dressing is vital. Clara Barton, Florence Nightingale knew that if the dressing looked crummy, there was probably bad business under there, right? The dressing marks the end of phase 3, the insertion phase, and the beginning of care and maintenance phase 4, right? So I ask, I'm in a room, say, full of inserters, and you guys can be surrogates for that, like, how long does it take to insert a central venous catheter? And this is the groups I usually get to speak to, right? What would a surgeon in your institution tell me? How long does it take a surgeon in your hospital to put in a central line, an acute central line?
5 minutes.
Around the world, the surgeons tell me it takes them 10 minutes to do this thing, right? Not by the stopwatch, just by their thing. The superior beings from radiology and critical care tell me that it takes 5 minutes to put in a line. And I was in Pittsburgh pre-COVID to a room like this, and the chief of anesthesia told me to my face that it takes him 2 minutes to put in a central line. So I said to him, buddy, I would like to see you get a consent in 2 minutes. And he was like, he didn't know what I was talking about. He did not know what that they needed, he didn't know, right? But I'm a generous guy, you can tell, right? Like, it only takes you 5 minutes. Take 30, look, take 30 minutes. Could you, I'd be any more generous than that, right? But how long does an acute central venous catheter dwell? And to a critical care group, that's a fair question. And the answer in the literature is generally 5 to 7 days. Now, should you argue with 5 to 7 days? No. So say 6 days, right? The math here is fairly simple. The 30 minutes of the insertion divided by the 8,600 minutes of the dwell tells us the insertion phase is less than 1% of the life of the catheter, right? And that the care and maintenance is 99%. So if you're going to impact infection, would you deal with the little orange sliver or the big blue pie? The action's clearly in the big blue pie, but they're related. The way we put them in, the way you care for it depends on the way they're inserted. And like, it's something that's just not spoken about nearly enough for my liking, right? And you got to realize, when the line goes in, it's over for us, the inserter, and it's just starting for the patient and for the RN that has to care for it, right? So basically, there are 5 phases in my framework for this thing. These 4 account for 1%, and the dressing, care, and maintenance accounts for 99% of the life of the catheter, right? So what happens after a central line is inserted? It's given to an RN to use and to manage. These things are nursing tools. We put them in, but then it's for the nurse to give the medication, to draw the blood, to do all the stuff, right?
So before we start, nurse, I could put this catheter in his neck or in his chest. Where do you prefer to care for it? The catheter exits from the chest or exits from the neck?
From the chest.
Why?
Because it's easier, usually the dressing will lie flat.
Thank you.
One enlightened nurse, you know? So I use the term proper insertion. What am I talking? Let me define that. What am I talking about for proper insertion? Number one, minimal attempts, hopefully 1. Like Matt Gibson was saying, 500 sticks on that arm thing. No, you want to get it in one attempt, right? You want the tip close to the cavo-atrial junction. When I go visit hospitals, that's not a thing. They'll tell you, guys, oh yeah, we need it. We want it down near the distal SVC. You look at the x-rays, it's nowhere near that, you know, but in vascular access, it's a cardinal principle, right? We want a proper exit site. And that's not the mandible, the hairline, or the ear. We want and this is permanent, right? We want to use sutureless securement, antimicrobial protection, and we want a dressing that stays on for 7 days with minimal to no disruption. Once I've done that, I consider that to be a proper insertion, and I'm, you know, kind of moving on unless there's an issue, right? So where are we? Phase 3, the actual insertion of the device, and we're going to get into the things. All right, so we're in the solution phase of this. So I say that there are 16 decisions, they're choices, and these are my recommendations. Now my partners tell me, Jack, this is too much to lay on people, 16 things. Like, we're gonna do this and this and this and this and this and this, and like, it's too much. But you're gonna have these decisions every time you place a line. So I'm gonna try to help you make the decisions of what's in the best for the patient, right? This is the paper I'm reading, and it talks about, you know, it's the guys from Italy, consensus paper, Mauro Pittaruti and his ilk, you know, talking about the basis, you know, consensus paper for the 16 recommendations, basically, right? So we'll go through the first 4. We're not going to go through all 16. We're going to go through them, some faster than others, right? These are, all right, the first 4. Recommendation number 1 is no more blind sticking. I'm sorry, right? If you put an ultrasound on the patient, you get these 4 things. You get to evaluate the vein, you get to evaluate the vein, you get to evaluate the vein. Anybody ever seen a vein that wasn't suitable for cannulation? Yep. Now go stick that patient blindly in the chest or the neck. Doesn't make that much sense. Basically, we want to evaluate the vein. We want to make sure the vein is not doing something like this. Now, I grew up blind sticking. I'm an excellent blind sticker, according to me, right? I think I might struggle if the vein was wiggling around like that. So in addition to evaluating the vein, you get to follow your needle through the tissue in that patient, something like this. You know, I actually let the resident try once. That was being foolish, and I got blood twice, but I couldn't keep my needle in it because it was wiggling around, you know. So decision number one, ultrasound guidance always. See, I'm helping the docs, you know what I mean? Like, just get that other thing. Decision number two.
You're not the one for me.
For those of you who haven't been dissecting necks, that's the internal jugular vein, right? What's my objection to the jugular vein? It's the most popular site on the planet. If I walk through your intensive care unit, I guarantee I would find some jugular action, right? What is the problem with the internal jugular vein? There are too many ways to do it poorly. It's not standardized at the highest level, which, you know, to spare the unnecessary variation, right? So for example, you could put it high in the neck, you could put it in the middle of the neck, and you could put it low in the neck, right? So vascular access experts, and I mean that, where do you want the exit? You want it low in the neck. Anything else is not standardized at the highest level. That, like, they have to come to this conclusion that, yeah, you can do it. You can do something different, right? So Dr. LeDun, principle number one for the internal jugular vein is low in the neck. It's mandatory. If you want to standardize practice at the highest level, it has to be low in the neck, right? I want to talk today a little bit about the catheter and the dressing as a unit. In other words, there's no dressing without a catheter. I mean, why would you put a dressing on somebody's neck if there wasn't a catheter there, right? And there's no catheter that doesn't have a dressing, right? So essentially the point is the catheter has to exit from the dressing, or you can't use it. You can't just coil it up like a snake under the dressing. You know what I mean? You have to have it exit from the dressing so you can use it, right? So basically, here's, say, a typical internal jugular, you know, insertion. And basically, the catheter can exit from the dressing, north or south, east or west. So now, here's an example of when the catheter exits from the east side of the dressing, right? And somebody that went to medical school put the dressing on the patient's mouth, and I don't know what to say after. I don't know what to say after that. Like, can't you just take 2 steps back and take a look and say to yourself, boy, I don't think that dressing's supposed to be on the patient's mouth. But no, they didn't do that. The guy was smart enough to graduate from medical school and stupid enough to do that, right? Now, suppose you have the catheter exiting from the west side of the dressing. You may have a little, you know, a little configuration that looks kind of suboptimal like that. The classic is the doctor goes to the head of the bed and the catheter exits from the north side of the dressing. And you've all, you know, seen this, you know what I mean? And I love, you know, sure, the dressing on the mouth, but the red flag, let's put adhesive tape on the hair behind the ear, because that's probably going to be pretty helpful to the patient, right? Or you can have the catheter coming out the south side of the dressing, right? So what's the goal? Standardizing practice at the highest level, you know, so to avoid the unnecessary variation. So which configuration standardizes practice at the highest level? Yeah. Yeah, and I mean, it's not maybe, it's not like we'll do it on this patient but not that patient, you know what I'm saying? And like anything else is not standardized at the highest level. Then another thing, they go, oh, it's going to kink. Yeah, I'm waiting for my first kink, you know what I mean? Like I did 7,000 of these and I'm waiting for my first kink, you know? So principle number one is low in the neck, mandatory. Principle number two is rotate it downward, mandatory, right? Then you see these beauties, right? What's the common denominator for these suboptimal insertions? They were all inserted from the head of the bed and the catheter directed upward, right? So instead of that, my teaching is to come from the side of the bed and puncture low in the neck and then rotate it down. So I consider this principle number three. No, so low in the neck, rotate it down, come from the side of the bed. Not mandatory, but I think it's a strong recommendation. It's the only way I teach it. If I'm teaching people, that's how I teach them to do this procedure, right? So basically, you got to learn this principle. And look at what they did to that patient's ear. It's folded and taped, right? So when you walk out of here, today, it's going to be, what was that guy saying? Basically, the ear is bad and the chest is good. If you want to simplify this, it's like the take-home message, The ear is bad for the dressing and the chest is good, right? In contradistinction to the internal jugular vein, the ultrasound-guided axillary vein, what your doctors call subclavian, is standardized at the highest level. Like, just because of this real estate, all of the axillary veins will look like this or have the potential to look like this, where I just showed the jugular vein has 20 different ways and 18 of them are wrong. Like, just because you put it here, they all have the potential to look optimal, right? So there's a paper from the Shea guidelines from 2022, the update to the 2014, and it basically says, and this is something, do you guys follow the Facebook Vascular Access group on Facebook? Lynn Hathaway's kind of subsumed it. Like the question's always coming up. The doctors put in a jugular vein and they say remove it and put in a PIC. This paper says that's not the answer to CLABSI, and that's come up a number of times. I don't know why. I would think that a well-placed PIC would be certainly the answer to a crumbly placed jugular vein, right? But this paper says basically the subclavian vein is the preferable site for central lines in ICU to reduce infections. Previously, their 2014 Shea compendium said to use the subclavian, but in order to avoid the femoral. But that was changed to a positively formulated recommendation regarding the subclavian vein. So in other words, it used to be, let's put in the subclavian to avoid the groin. Now they're saying, no, this is the right place to go to prevent infections, right? What does the CDC say about this? This is the guidelines of the CDC. 75-page document. On page 11 and page 27, it says the same thing for whatever reason. Article 3, page 11 and page 27, use a subclavian vein rather than a jugular or femoral vein. Article 7, use ultrasound guidance. To the people in this room and the CDC, let me explain that when you say ultrasound and subclavian, you're talking about the axillary vein. And this is what I'm talking about. When the basilic vein comes up the arm, when the brachial joins it, it becomes the axillary vein. It travels up in the deltopectoral groove as the axillary vein, and when it gets to the lateral border of the first rib, it changes its name, and it's now the subclavian vein. You can't, because of the bones, you can't see it with ultrasound. So whenever you're looking with ultrasound, it's the axillary vein. Try to explain that to one of your critical care doctors, and like, don't even bother. Leave that to me, you know what I mean, right? And basically, this is a picture of, there's a PIC line in the axillary vein going into the bony tunnel. And I love that, you know, I love that picture. So like as a surgeon, I've seen the axillary vein, I don't know how many times, countless. I've seen the subclavian vein, none. I've never seen the subclavian vein exposed. It's in a tough spot, you know? So that's why when you use ultrasound, it's the axillary vein, right? There are many things we disagree about in the field of vascular access. We agree about this. The optimal location for the dressing is on the chest. Why? Less motion, it lies flat, it can stay intact, all the good stuff, right? So our friends from Europe, and Ostroff, and I think Dawson's on this paper, they made like a red, yellow, green, like for the zone. You guys all familiar with the zone insertion method in the arm? This is the zone insertion method for the neck. We don't want it up near the mandible or the hairline. We want it down on the chest as much as possible. And this is what it looks like, right? So basically, there are 3 ways to achieve a dressing on the chest, which we want. Number 1, puncture a vein on the chest. When you use ultrasound, the name of that vein is the axillary vein. The second way is to do a percutaneous jugular vein, then rotate the catheter downward. And the third way would to do a low IJ and tunnel it out to the chest. Number 1 and number 3 are standardized. The axillary vein procedure, they're all standardized. The tunnel jugular vein, they're all standardized. They look good. Number 2 is not. And I just showed that with the, you know, the different configurations. So moving on, we're going to show some procedures. We're going to show a percutaneous axillary vein procedure. That dashed line is the deltopectoral groove. The axillary vein lives in the deltopectoral groove.
She has a nice axillary vein. So we're going to be puncturing our axillary vein inside of the humeral head in the deltopectoral groove.
We use micropuncture equipment. We're not going to cut the skin. The skin is the natural barrier to infection.
Give a nice skin wheel on the way out. That's staying, ma'am?
Yeah.
What, just a second. Get it to you.
That's actually Matt Gibson. I was bringing him to his first axillary vein. There's my needle in the axillary vein. The artery's to the left, the pleura is below.
You have good flow? Then we push down on it. We just get it to 20 centimeters. So we're going to maintain a little back traction.
We don't cut the skin. We use micropuncture equipment.
Threading the catheter over the wire. I would go to about 7. All right. So, okay, and there's our blue bullseye. So you'll see we're right in the deltoid rectal groove, right where we marked it. We're doing a medical procedure here. When you pay your bill, all right, so we're going to put on the securement device. So we're going to put this on, and we're going to get it to the hub. All right, good. So here we have an ultrasound-guided right axillary puncture. The dressing's in the right place. Turn your head to the side. We're giving it to the nurse in proper position where she can provide proper care and maintenance. We did not incise the skin. We did not suture it down, and the hub is not all the way into the skin.
I used to say, does that look like it's preventing infection? But I've changed it to, does that dressing look like it'll stay on for 7 days? It does to me, right? So basically, based on the guidelines, the SHEA, the CDC, and the underlying studies, my considered opinion is that the ultrasound-guided axillary vein is the location of choice for infection prevention considerations as long as they don't have chronic kidney disease. And basically, I want you to ask your doctors, like, hey doc, why don't you say subclavian? Let's not get into the axillary. Let's not give them a headache. Doc, why don't you use the subclavian vein? The CDC seems to recommend it. The SHEA, like, see what they say. See what answer they give you and see if that answer makes sense to you. I'm here saying, I hope nobody's confused about what I'm saying. I'm saying this in ICU, if they don't have kidney disease, that's where I put it, unless there's some extenuating circumstance. Why? For the nursing care, for the care and maintenance, the relationship between the way inserted and the way these things are cared for, right? Moving on, we're in phase 3, the actual insertion. Well, I'm not going to talk about micropuncture equipment and not making an incision. I just showed it, and I'll show it in future patients, right? So, I asked the question, how long is a 20 centimeter catheter? What could that possibly mean? Nisha, how long is a 20 centimeter catheter? The manufacturer gives you another 1.5 centimeters past the 0 mark. So if you shove it into the hub, it's a 21.5 centimeter catheter. But now you can put on a proper dressing so nurse can cleanse it. And if you want to use the chlorhexidine sponge dressing, it'll fit underneath there, right? I like the antimicrobial catheters. I think that's recommendation 8A of my 16. Okay. Has anybody ever seen a catheter put into the hub? The nurses don't like it. They can't come by and clean it. They can't put on that disc, you know. So basically, this is what I'm talking about.
This is a 20 centimeter catheter is 21.5 centimeters in length. You can see that the company has engineered this so that I have room to put a proper dressing. I do not have to stick this into the hub, but I've got 1.5 centimeters in order to put a proper dressing on this thing without sticking the catheter into the hub, which I don't. All right, so I have my
You know, does that dressing look like it'll stay on for 7 days? Yeah. All right. So basically, and what, you know, dovetailing for what Nisha said and Matt Gibson, the same thing. Before we do anything to the patient, there's the transient and resident flora that hang out on the skin. That's, you know, that's a pictogram depicting, you know, what's on our skin, right? Once we prep the patient, we get about a 4-log reduction. 99.99% of the bacteria are eradicated. But like what Nisha showed, and Matt the same, between day 2 and day 7, the bacteria repopulate. That's what they do. So we don't want the skin to look like this on day 2 to 7. We want it to look like this, like it did right after we prepped the patient, right? So, and, you know, just following up, where do the bacteria come from? About 60% are the skin organisms. So we really got to be scrupulous. We can deal with the skin organisms. So how do we deal with it? We have an antimicrobial catheter, and we wrap it with the active ingredient chlorhexidine, and this is how you prevent infections. This is like my mom says, there are 2 ways to do things, right? So basically, that orange is sodium hypochlorite. It's a stain for the active ingredient, namely chlorhexidine. What I like is that the active ingredient is on the skin where the catheter goes through it and damages it. That's where I want the active ingredient. I don't really care if there's chlorhexidine out here. I want it right there where it's wrapped around the catheter as the catheter is damaging the natural barrier to infection, right? There are other products that have chlorhexidine containing dressings, but they don't have the same configuration. In other words, the hub is blocking, like the chlorhexidine doesn't travel. It binds tightly to the skin where it lands. It doesn't like percolate and do this. It just lands right there. So I want my chlorhexidine right around here, but you can see what the catheter hub is doing, that it's blocking the chlorhexidine from getting underneath it, right? So why do I like the CHG disc? And it's good, like following up on Nisha, like it elutes the active ingredient. So it has the disc has 92 milligrams of chlorhexidine in it, and it elutes it continuously. By the end of day 1, and this is exactly what Nisha was talking about, it's eluted 25 milligrams of the 92 onto the skin by the end of 24 hours. By the end of 3 days, it's eluted 60 milligrams of the 92. And by day 7, it's eluted 60 milligrams, and then we change the dressing by convention for that. So let me just, I don't know if I showed that slide twice or not. All right, so the question becomes, is this the era of evidence-based medicine? I'll tell you how I learned. When I was coming up, it wasn't the era of evidence-based medicine. Like basically, you did what the smart guy in front of you told you to do, and he did what the smart guy told him to do, and the guy in front of him made it up. There wasn't evidence-based, but more and more, it's evidence-based medicine. Like the evidence supporting the CHD disc far outstrips all of the evidence for any of the other chlorhexidine-containing products in the history of planet Earth, right? So in the past, before the Shea Compendium 22, CHG dressing was listed under special approaches. In other words, if you did everything right and you still saw infections, you would add a chlorhexidine-containing dressing. That's been changed. The use of chlorhexidine-containing dressings is now considered an essential practice. So if you're not using it, you should really be explaining why. All right. Talking about infection, there's a conflation of ideas. In other words, I'm not a salesperson, I'm a clinician, right? But basically, you can prevent an infection, you can detect an infection, and you can treat an infection. These are not the same thing. But when you hear the reps, they get conflated into like, so how do you prevent infection? Basically, you put the catheter in properly. My friend Nisha, not a clinician, did not get into that. But like, there's no way around it. There's no way around preventing an infection if you're not putting in the catheter properly. And then you wrap it with a chlorhexidine disc. This is how you prevent infection, right? So visualizing the site. This comes up, one of the things you'll see a rep, well, you put that disc on there, you can't see the site. Never, so I've undergone biometric testing down at the Armed Forces Institute of Pathology in Bethesda, down where I live, right? My gaze has no antimicrobial effect. I'm one of the few. I can look at a wound all day long, and I've yet to prevent an infection. In fact, never in the history of life on planet Earth has looking at an exit site or surgical wound prevented infection. That's not how this works, right? Now, here's a patient that has one of these ugly jugular things and a number of peripheral IVs. If one of these PIVs causes a bloodstream infection, what's the name of that? Clabsy, because of the jugular line. If you're going to protect this, you better protect the peripherals. And who knows if these are just in case, whatever, just in case not working, right? So why do I like the CHG disc? It wraps around the catheter where the catheter is damaging the natural protection, infection prevention, the skin, and it's got a mountain of evidence supporting its effect, right? All right, moving on. Where are we? Phase 3, the actual insertion of the device, 16 recommendations, right? So I'm into like numbers 9 and 10. So basically the standards, you know, Matt was all over the standard. I believe it's a great book. Avoid the use of sutures as they're not an effective alternative to an engineered securement device. They're associated with needle stick. I've had my share. They break. Biofilm formation, increased risk of infection. I mean, find me somebody that recommends sutures. You know, but I mean, these things like get carried on and they don't get carried out. You know, they just get handed on. I think Ambrose Paré was the father of sutures in Paris in like the 1500s. You know, so, you know, CDC used sutureless securement. All right. So, the optimal location for the dressing of the chest. We made that point, right? All right. Experts in the room, what is a good reason to use the internal jugular vein? In fact, the reason. Yes, ma'am. Winner, winner. If the patient has chronic kidney disease, that is the reason to use the internal jugular vein, right? What is a bad reason to use the internal jugular vein? Convenience. That's a bad reason? That is theoretically a bad reason. So I say, somebody with a tracheostomy, like, you're out of your mind if you think that's a good spot to put a central venous catheter. Even one of Nish's fancy antimicrobial coated catheters, right? But, so anybody ever see a patient with chronic kidney disease that has a tracheostomy? So the chronic kidney disease, they want you to use the IJ vein. And for the tracheostomy, Dr. LeDun doesn't want you to use. So what's the solution to this? Mid-thigh. Mid-thigh is a solution, or we can tunnel it. We can go in the jugular vein and tunnel it out to the chest, right? So on this video, I want you to pay attention to, I'm going to nick the skin because I'm tunneling. I use a 14-gauge angiocatheter. RNs are doing this procedure at the bedside. So the critical care guys have to adopt this procedure. This is a great procedure. A little, ooh, I could live with that. My needle going into the 9 o'clock position in the internal jugular vein, avoiding the periosteum and the clavicle, micropuncture equipment.
There's our tunnel catheter going into the tunnel and exiting. So up here.
The rest of this is a PICC insertion.
Okay, feels like it's going in properly. So I'm going to remove the peel away. The catheter in, I'm going to remove the peel away. We have in deeper, so this is telling us where the exact right.
The critical care guys don't use EKG tip location. Like, what do you have? Like, what's up? I asked them once why they don't. They said they never heard of it.
I'm going to release and
okay.
deploy.
If I'm going to the trouble of tunneling, I'm going to use this fancy securement, permanent. It's a permanent securement device.
Like this, and we're going to put the top on. Okay. Looks good on this side, looks good on this side. The last thing we have to where the dressing is going to go.
I like to use a gum mastic liquid adhesive. I want my dressing to, I don't want to invade it for 7 days. It's the relationship between the way we insert it and the way the nurse cares for this device.
Now permit that to dry for 30 seconds. It's going to go right here. You can feel the way it goes down. Sticks down very nicely. Dressing. So this is what I consider to be modern vascular access.
To the students in the room, you will be doing that procedure in New York State, hopefully before I shuffle off. And please let me know if you get a chance to do it, but it's truly a great procedure. We don't go to the IR lab, we don't go to the OR. You know, it's RNs doing this at the bedside in the country, not in New York State. Okay, so moving on, 16 recommendations, right? 55 years ago, an English physician named Ian English described how to do an internal jugular vein catheter, right? But in 2024, we don't have to do it his way. If you practice anesthesia like it was 1969, you'd be out of date as well, right? Here's a paper Here's a paper from Jonah Kaparis's last hospital where they're talking about basically what I'm talking about. Quality improvement in, in CLABSI, right? So their analysis, famous hospital on the east side of Manhattan, their analysis revealed that CLABSIs were most frequently associated with internal jugular vein access. There's a little bit of a theme to this talk, right? But now they're going to explain to you why they used it. Their data showed, so like, I don't get that. Like if my data showed that a particular procedure caused an increased risk of infection, I would do something else. That's my way of, obviously I didn't get that right either, you know. But, so they're going to explain their reasons for choosing the jugular vein, knowing that it causes a higher risk of infection. Is that about the philosophy in a hospital like that, Jonah? Is that the common sense that goes on in a place like that, right? This is why they use the internal jugular vein. Number one, their patients are sick. Now, wait, let me go on the record. At the height of the viral epidemic in April 2020, their ICU was on the national news every night, and the patients looked dreadfully sick. They're no sicker than your patients, right? And I don't give sick patients, because of their sickness, have an increased risk of infection. I don't give them a procedure that has, like, I don't get it, but I can't think like the big hospital on the east side of Manhattan, right? And the second reason why they're going to use the drug, they're training residents. And I always say, if anybody has a weapon, please end my life right now. I don't like this makes me ill. Like when I'm training residents to do this procedure, they learn to do it my way. I don't dumb it down to them. The fear of pneumothorax, no, they learn to do this thing properly. And the third reason that they pick for using the jugular is that the subclavian, in quotes, is not easy. Now we know it's the axillary vein, right? And they're right. It's not easy until you learn how to do it. And then it becomes pretty yeah, it's not as easy as the jugular vein, but don't do it and it doesn't get any easier. You learn how to do it and then you have the catheter in the right spot, right? All right, 5 procedures, internal jugular vein. I was at the big institution, Jonah Kaparis. They can name a wing after Jonah and Jeannie, right? And I was going in to view a procedure. And I guess we'll get in. Patient with C. diff colitis. And anyway, I'm going in to watch this procedure, right? At the famous hospital. And I'm on the way in and I said, by the way, I've got my video camera with me. I know you're not going to let me use it. And they're, yeah, sure, go ahead, take a video. So now, like, you have somebody from the outside the institution with an unstable personality and a video camera. What could go wrong here? So I label this video, how not to insert an internal jugular vein catheter, right? Like, they start at the head of the bed. Where do you think the dressing's going to be when you start at the head of the bed? Yeah, ears bad. They did use ultrasound. Otherwise, it's in Ian English in London in 1969. They used, no micropuncture equipment. Huh. Patient's unhappy. Note the ear. You're not supposed to see the ear.
I knew it was ended.
Okay.
Now,
All right, 20 is plenty, so. Take a picture.
first approximate to the skin.
I thought he was going to dilate without cutting the skin, but no. But he made a nice little baby Nick. I'll give him that. I don't do that, but.
What do you call it? Patch? Thank you. Patch.
All right, let's snug it down nice and tight with the suture to really help the nurse out. Really, this is a TPN line. They're putting this line in for TPN in a sick inpatient in a famous hospital right across from the park. Get the ear out of the way. Shift the ear out of the way, buddy. I don't use heparin. No. So.
Nice work.
So I told the fellow nice work, and I didn't mean it at all, but I was being polite, you know what I mean? And I communicated with him, afterwards and tried to, but, it's hard. It's like this is a famous hospital. Everybody knows this hospital. It's coming out north side of the dressing. What's it going to look like on day 4? Yeah, clearly, right? All right. The zone insertion method. Does everybody know about the zone insertion method? If you don't have to admit it today. Send me an email. I will send you the paper. You have to know about the zone insertion method, right? So basically, the great Robert Dawson, it's simple. Like you put picks in the middle of the arm. You don't put them near the armpit. You don't put them near the antecubital because that's where they belong, right? So basically, for the jugular, the same thing. There's a zone insertion method for the neck as well. We don't want to put it high. We don't want to put it in the middle. We want to put it low in the neck, right? And then a year after English wrote his paper, this was Jernigan from Kentucky, like coming from the side of the bed, not the head of the bed. But look what they did with the catheter after they got it in 1970. They rotated up across the patient's forehead because they didn't know any better. But like today, we want it low in the neck and rotated downward, right? So basically, we're in agreement. The optimal location for the dressing is on the chest, right? So this is how I recommend doing a percutaneous jugular vein catheter.
In the neck, we're going to puncture the vein as low down above the clavicle as we can. So it looks like it's right in the jugular vein.
My needle in the jugular vein, micropuncture equipment, of course. Side of the bed, low in the neck.
Now the wire's good. See that we're nice and low in the neck. We're not in the middle. We're going to put the 5 French micro introducer over the 0.18 inch wire. Okay. We're not going to cut the skin because the skin is the barrier to infection. This feels like it's going to move. The inner cannula and the wire. We're going to put a finger over the hole from the set. We're going to put this in to about 8. Now we're going to dilate with the 7 French dilator. Okay, it's going to feel a little bit of pushing now. Just go in. Okay, so go in the rest. Okay, there. That I'm going to put in the 7 French triple lumen catheter.
Antimicrobial Nishigupta catheter.
Going in smoothly. We're going to put this into about 19 to 20 centimeters because the nursing step, where would you rather care for this catheter, in the neck or in the chest?
Just.
There's a theme. There's a theme here. There's a pattern developing here. All right. So now, we're in phase 3, 16 recommendations. So I usually tell people, I think I've made a strong case for the 12 recommendations up to this point. This one I insist on. It has to be done this way.
We're going to fold this thing down toward the chest, not up near the ear. Okay, I do not want this dressing up near the middle of the neck. I want it down toward the chest where it belongs. So we're going to put it on with the slit facing the catheter, and we're going to offset it up just a small amount, maybe about 10 degrees. Of the catheter, the skin prep. Okay, so we're going to take off the rest of it. Thank you.
All right. I'm getting out $20. I know I got a $20 bill in here someplace. All right. Trust me for the $20, okay? But you see, like, so that's coming out the bottom of the dressing, right? So I contacted Lisa Gorski, and I was talking about it. She called me back last winter on a Sunday. Basically, we all know dressing disrupted, change the dressing. We get that. Standards of practice, standard number 32, whatever standard is, right? You have to ask, why is it disrupted? It's not enough to change the dressing. There's $20. Oh. Why is that dressing disrupted?
Gravity.
Did you read it or did you know it? Okay, $20. $20 back there. You're good for 20. Okay, right. The catheter exits from the top of the dressing. We already decided low in the neck and rotated downward. My mother would be sorry. I'm giving away $20 for that. Like, it's gravity. Gravity's the inexorable attraction of the heavenly bodies for one another. Like, you know, it's going to just pull it. It's going to, you put a directed catheter upward, gravity's going to pull it toward the floor, and it's going to disrupt that dressing. The ICU nurse is magical with that bacteria-laden roll of tape in her pocket, and it doesn't matter. It doesn't matter. Gravity wins every time. And the patient we just showed, the tails are coming out the bottom of the dressing, and gravity's working with you. It's got to be done that way if you think an intact dressing is important for the patient. Okay. I don't think you guys realize how good I am at this, right? And I'm going to tell you, so now I'm going to tell you. I'm going to tell you which catheter in your hospital has the worst infection record, right? And I've never been there. I've never been in your hospital. At every hospital I go to, the acute hemodialysis catheters have the worst infection record, right? This is Mackey's work from about 15 years ago, right? And so I was lecturing on this, you know, for the docs, and the chief of surgery interrupted me.
Yes, sir.
I was just going to ask, why do you think the HD catheters have the highest? I don't want to say it's because the people who put them in do it wrong and everyone else does it better. Is it the access? Is it the patient accessibility?
There's a whole bunch of reasons for it. One of them is, like this catheter here. This is lipstick on a pig, as far as I'm concerned. This can't be put in the way it's put in like this, and it's folded down so it doesn't wind up in your auditory canal. No dressing with this catheter has ever stayed intact. So it's almost like you're defeated by the equipment. They're heavy catheters, but all the factors, the patient just...
So there's a patient of mine, needed acute hemodialysis catheter, 7-year-old guy in the unit on an endotracheal tube with a beard, septic shock, organ failure, DIC, his INR was 4, right? So we're going to pay attention to the steps. I'm working with a resident, he's doing some, I'm doing some. Coming from the side of the bed, low in the neck, rotating it downward. Chlorhexidine sponge disc, gum mastic, liquid adhesive, micropuncture equipment, no skin incision, right?
Look at the probe. Hit the center of the probe, Christopher.
Good.
Hit the center of the probe. I'll tell you when to look at the screen. You look at the probe. Disconnect. Pinch it.
You think I want to cut the skin in this guy with an INR 4?
Slowly.
I do not.
So we're going to sink that.
So it has 2 dilators, an 8 French and a 12 French.
I want to cut the skin of this man with an INR of 3.9? 4. Okay, now because it's been dilated once, we should be able to get this appropriate.
Now that's a dilator.
Okay. Okay, that's 20. So teaching point is, in a patient like this with a short neck, on a ventilator with an endotracheal tube, we do not want a dressing up near the mandible, the hairline, or the ear. We want it down on the chest. Nurse, where do you want the dressing this patient, on the neck or on the chest? Why? Because it lies better and you can provide proper care and maintenance?
Yeah.
Did I put words in your mouth?
Yep.
Dressing is going to have a good chance to stay on for the 7 days. Good.
Sorry, you're okay, sir.
You're okay.
It's almost over.
Relax. You're all right.
Okay, and I can feel the dressing going on. Very nice, very in a sticky position. So we're going to retract all this. Good.
Is that what dialysis catheters look like in your institution? Why not? It's 2024. That's somebody's relative, somebody's loved one. Why don't they look like that, you know? All right, I'm going to summarize this thing. Appreciate the time that you gave me. Infection prevention is an organizing principle of vascular access. In other words, whatever we do, like Nisha Gupta and Matt Gibson and myself, it has to have infection prevention ramifications. You got to think about this. The guidelines will tell you to do hand hygiene and maximum barrier precautions. The manufacturers will sell you antimicrobial catheters and antimicrobial dressings. They will sell you special end caps. They will even sell you antimicrobial caps for those special end caps. But on your list of infection prevention measures, where is insert the catheter properly and dress them properly. And there's a cost for this. It's nothing. You don't have to buy anything. You just have to learn how to do this, right? Back to the life cycle. People are going to come to you all the time, like today. Nisha Gupta, Jack LaDunn, Matt Gibson, Lori. I don't know what she's going to be. We're going to have new stuff. Like, you're going to tell a rep about the problem you're having in your institute. They have the answer in their bag. Oh, you have it now? He'll fish it out. He'll give you a couple of samples. They have the answer in their bag. Some of the new stuff is special dressings, end caps, CHG bathing. If my patient's in the intensive care unit and somebody put in a central line and it's hanging off them like this, please don't bathe them with chlorhexidine and think that you're helping them. Please put the line in properly and dress it properly, right? Locking solution has my interest because it deals with the intraluminal pathway. Most of the stuff we're talking about is the extraluminal. Now, whether you buy this stuff that's going to save your hospital infections or not is up to you. But I ask this, did you do this first? This is the basics. You assess the patient in standardized fashion. You do the pre-insertion bundle. You put the line in properly and you put a dressing on. At that point, if you want to buy something that's going to help you, be my guest. And if you don't do the basics, you get what you get. Suppose there was a study that showed the outcomes from this were the same as the outcomes from that. Wouldn't you do it this way anyway? You don't need the study. We have to stop teaching those procedures that they've never worked. They have hey, if you want improved outcomes, there's a way to do it. When you walk out that door, that guy was talking a lot of stuff. The ear is bad and the chest is good. How do you prevent infection? Mom, do everything right. Insert the catheter properly. Don't put it into the hub. Wrap it with chlorhexidine and have quality, optimal care, nursing care and maintenance. I have to end it with Gracie. Hey, listen, I want to thank you for your attention. It was great. I love being here. And we won't get into that. So I'm flush up on 3 o'clock. If there's a question or two.
Yeah, absolutely.
If anybody has a question.
Have a question for Dr. LaDunn?
And yes, ma'am.
Just real quick, our ICU intensivist, we've talked to her about the placement on the IJ, and she said absolutely not ever to teach or tell the fellows to go low IJ because of risk of pneumo, but what can we say to that?
What can I say to that? Okay. So why don't I've had that question so much,
Yeah.
I've built it into this, right? So they're scared of pneumothorax, right? Is the fear of pneumothorax rational? Like compared to CLABSI, so let me compare pneumothorax and CLABSI, right? We're going to look at these things here. We're going to look at morbidity, mortality, extend the length of stay. You can't read that, it's too small, right? So pneumothorax, wow, I can't read. The morbidity is minimal, but the morbidity for CLABSI is extreme. Heart valve infections, lumbar infections, it doesn't compare, right? Then, let me stop that, okay. So one of the things, you can't read this. So one of the things is why they, you know what the mortality for CLABSI is? It's 12 to 25%. For an iatrogenic pneumothorax in a hospital, it should approach 0, right? But the thing about pneumothorax is it's attributable to you. Everybody can deny that they caused the CLABSI, but they can't deny. So for them to be scared of pneumothorax, which can be corrected, let me see, let me just go through this. If you can learn how to follow your needle through the tissue, and I have an example here, if you can do this, it's a technical answer. If you can follow your needle through the tissue down to the vein, you're not going to get pneumothorax. You know what I mean? But to prevent CLABSI is a whole nother, I find it it's fear. The only thing we have to fear. You know what I mean? So it's, all right, thank you. I'm going to, if anybody wants to ask questions while I'm breaking down, fine, but we're going to make room for young Lori to give her talk. But thank you for that.